Hello, everyone. Thanks for joining us on Total Health Advanced Care Through Education webinar. We have a special treat for you today. We have a little bit of a different, unique webinar. Instead of just having didactic talks about the disease, we're going to get today a patient perspective. And so the title of today's webinar is going to be Global Perspectives, Shifting Points of View, including the patient experience. And I think that's going to be a really valuable part of today's discussion. So today we have two physicians, CML experts from around the world. We're fortunate to have Dr. Carolina Pavlovsly from Buenos Aires in Argentina, and myself, Tapan Kadia. I'm a leukemia doctor in Houston, Texas at MD Anderson Cancer Center. And joining us on this webinar with patient experience, we're going to have several patients, and I'll let them introduce themselves here in just a second. But what I wanted to emphasize and point out is that we have a wide variety of patients from all over the world. I think the unique part of this webinar is that we're really getting perspectives not only from the US and South America, but also Malaysia, the Philippines, India, and I think we'll really have a nice discussion today. So I'll let the rest of the participants kick it off, starting with Dr. Pavlovsly.
Hello to everyone. I'm Dr. Carolina Pavlovsly from Buenos Aires, Argentina. I will be moderator also with Dr. Tapan Kadia, and I'm really happy to be here because I like to be in touch and share this experience with doctors and patients. So thank you for the invitation.
Thank you.
Hi, I'm Viji Venkatesh. I'm the region head for South Asia with the Max Foundation, based out of Bombay. Very happy to be on this webinar along with so many of these patient advocates. The Max Foundation has been part of a patient access program for imatinib, Gleevec specifically, and we literally have thousands of patients who continue to be on the drug and face their diagnosis of CML. Thank you.
Good morning, everyone. Good morning from Indonesia. I'm Andrian Rakhmatsyah. I'm patient from Indonesia CML NGS community. I am CML patient as well since January 2011. Nice to meet you all, and yeah, I'm happy to be here.
Good morning. My name is Kel Dijamco. I'm an 11-year CML survivor. I am a patient advocate here in the Philippines. Basically, what my group does for the community for CML is we educate folks as far as CML, and as well as provide a roadmap how to access medicines and access lab works, since it's very expensive here in the Philippines. So yeah, that's who I am and where I'm from. Thanks.
Thank you.
Good morning, everyone. I'm Najha Johari, representing Max Family Malaysia, a patient support group of CML patients and rare cancer disease in Malaysia. So I'm also a patient, a CML patient since November 2015. It's nice can join you guys this morning, and I'm happy to be here to share my experience. Thank you.
And then we have finally Dr. Vaz.
Good morning, everybody. I am Dr. Jude Vaz. I live and work in Bombay, India. I'm a pathologist by profession, and I have been a CML survivor for the last 17 years.
Thank you. Thank you, everyone, for introducing yourself, and we're really glad to have everyone to get their perspective. And so what we're going to try to do, and this is sort of a general outline and discussion points that we're going to try to cover with this webinar, we're going to look at potential questions, right? So questions that come up from the patient perspective, but also from the physician perspective. And I'm sure each of the patients and the patient advocates on the line will tell you during their own journey with their CML diagnosis, from the diagnosis to the treatment to surveillance, I'm sure many of these questions popped up into their heads. And I think I'll be interested to get their perspective about how they were dealt with and what points and advice they have for us as physicians about how we can frame these things better. At the same time, as physicians, myself and Dr. Pavlovsly often want to know certain information from patients when they come to see us, not only from the patients themselves, but also potentially from their caregivers to get an idea of how things are going, toxicity, compliance, etc. We'll start the talk off with the basics of CML Many of the people who will be watching this, maybe this is the first time you've heard of CML. Maybe this is the first time you've been diagnosed. We'll go over about what that means instead of in a very simple, basic way, but also to describe some of the terminology that we use. As physicians, we sometimes say things like cytogenetics and PCR and quantitative PCR and what's your BCR-ABL. And all these things are very quick. And sometimes people who are not trained in this, it's difficult for them to understand that. And I think that I'm going to try to break it down for you as best as I can. And I'm going to hope that my patient advocate friends here on the line will stop me and say, hey, could you explain that a little bit better so that that you guys understand. Then we're going to go then into, so I'm going to do part of the basics of CML. Then Dr. Pavlovsly is going to cover a portion about monitoring and surveillance and further outline of CML. And then we're going to jump into the patient experience. And we want to hear from our patients and patient advocates on the line as to what their experience is, not only home care, but how do they manage adverse events? How do you partner with your doctor to manage this and emphasize the importance of monitoring as well as compliance with the medication. So I'm excited to get started and I'll jump right into it. And so this is just a very basic of CML, which is chronic myeloid leukemia, right? So leukemia essentially means cancer of the white blood cell. So it's a malignancy, it's a cancer of the white blood cells. And so you've often heard of acute leukemias, which are often the more aggressive type of leukemias that are very rapidly progressive, and they're often medical emergencies. So this is the leukemia you may have heard about either from friends, family, on TV, where people come in with very high white count, they get very sick, they have fevers, they get into the hospital, they need chemotherapy right away. You may have seen people lose their hair when they get chemotherapy. That typically describes acute leukemia, a rapid form of progressive disease. This is a chronic leukemia. And the difference is that chronic leukemia generally deals with the same cells, but a mature version or a grown-up version of the cells, whereas acute leukemias deal with sort of the immature early version of the cells. And so chronic myeloid leukemia is a malignancy of these mature blood cells. Now, the differences are that although CML and other chronic leukemias can lead to very high white counts that can be rapidly progressive, in general, they're a little less severe than acute leukemias. That's not to say they're not dangerous and don't need to be treated quickly, but they tend to be a little bit more manageable and they're less of a medical emergency right away in most cases. And so as any other malignancy, CML, it leads to uncontrolled growth of malignant white blood cells that start proliferating in the bone marrow, which is inside your bone. They proliferate in the spleen, which is in your left side of your stomach, as well as the liver. And when they start growing in these areas, the spleen gets really big, the liver gets really big, and your bone marrow gets full of these sort of malignant garbage type cells that do nothing but just grow. And as a result, your other blood counts may start dropping. So your red cells may drop and that makes you anemic and people get short of breath or need a transfusion. If your platelets drop, which is not as common, you get thrombocytopenic or you have bleeding issues and bruising issues. When your spleen and liver get big, they can be painful. People may eat less than usual because their stomach gets filled very quickly. They tend to lose a lot of weight. They have abdominal pain. So those are the signs and symptoms of CML. Occasionally, people may also present with shortness of breath. They may present with fevers, bruising, other things. But overall, it is a cancer of these white blood cells that are growing rapidly. There are phases of CML. Patients always ask me, well, what stage am I? Am I stage 1, 2, 3, or 4? So in leukemia, we tend to not have stages, but CML specifically has phases. And I just told you that CML is chronic myeloid leukemia. And so there is a chronic phase, which acts just like what I told you, very slow, indolent, but proliferative disease. And on the other end of the spectrum is blast phase. That actually is CML that looks like and acts like acute leukemia. And that is a medical emergency that needs to be treated quickly with chemotherapy and special targeted drugs. It's not common that CML presents right away as a blast phase, but it can happen. A lot of times CML that's been ongoing for a while or neglected can sometimes accelerate into blast phase. An accelerated phase is somewhere right between there where it's rapidly moving, needs urgent therapy, sometimes chemotherapy. It's not as slow and indolent as chronic disease, but it's not as aggressive as blast phase. But if you leave it untreated, it will likely progress to a blast phase. So that's CML as sort of definitions of what it is and the different phases. What I wanted to introduce now is the concept of chromosomes, right? We all, or maybe we don't know, but many of us may know what chromosomes are. Chromosomes are our genes, right? That's where our genes are on our DNA and our genetic material. We all have 46 chromosomes. We have 23 pairs of chromosomes. We get 23 from our mom and 23 from our dad. And when we're born, they come together. And so we have 46 chromosomes or 23 pairs. This makes up your entire genome or your DNA. And on these chromosomes are different genes. The chromosomes are numbered from 1 to 23. And usually they're in every single cell, the chromosomes are absolutely identical. What happens in leukemias, and particularly in CML, are chromosome abnormalities. In other types of leukemia, you may have missing bits of chromosomes. They may be chromosomes that are stuck together. They may be chromosomes that are broken. These are called chromosome abnormalities. That means the actual structures of the DNA in these chromosomes are broken or messed up. And the important part of that is that you can actually detect these chromosome abnormalities under a microscope. A pathologist, like Dr. Vaz, for example, can look under the microscope, see the chromosomes line up and say, hey, these are not right or something's wrong. They don't look like the normal 23 pairs of chromosomes, something stuck to each other. And in fact, this was how the first discovery of this abnormal chromosome was made many years ago. And that abnormal chromosome is called the Philadelphia chromosome. You'll hear this a lot, Philadelphia chromosome. And what that means is that in patients with CML, within their CML leukemia cells, their 9th chromosome is stuck or attached abnormally to their 22nd chromosome, leading to a translocation called 922. So a 922 translocation is the Philadelphia chromosome, and it leads to putting 2 genes together, something called BCR and ABL. So BCR-ABL, when they come together, that's abnormal. That should not happen in normal cells. But when it comes together, it forms this gene or oncogene that produces CML, okay? And that's why it's so important to know this for patients, because they can then understand, aha, this is what my doctor's talking about. The BCR-ABL is those 2 genes that come together within the Philadelphia chromosome, and they actually drive CML. And so now you can use this marker or this gene fusion to detect CML. You can diagnose very clearly that this is CML and no other disease. It defines CML, chronic myeloid leukemia, but it can also be measured quantitatively. So could you imagine now, we can say when you start, you have 100% BCR-ABL, and when you get treatment, and Dr. Pavlovsky is going to go through this in detail, you have a drop in the amount of BCR-ABL, and that actually correlates with how well people do. Okay, so if you have a 0% BCR-ABL, that's great. That's complete molecular response, and that suggests you're in a very deep remission. And so we can measure this in different ways. Like I said, cytogenetics, which is looking under the microscope. There's something called FISH, which is fluorescent in situ hybridization, which is a little bit more sensitive. And finally, PCR, which is a DNA test that can be very, very specific and quantitative. All right, so this is the Philadelphia chromosome that I mentioned. You can see here that part of chromosome 22 gets stuck to part of chromosome 9 and forms the BCR-ABL translocation that's listed here, and that's what gives you CML. So one of the important parts of CML is not only the treatment, because the treatment actually is very good. We actually have drugs that can actually bind BCR-ABL and turn it off. So, what I didn't mention is that when BCR and ABL come together, it acts like a switch, like a light switch that turns on, but it's left in the on position. Normally, our cells are very, very good at turning on and off switches when you need growth, when you want to stop growth, when you need proliferation, when you want to stop proliferation. It's very tightly regulated. But when the BCR-ABL come together, it's like the switch is left in the on position and you can't turn it off. So these drugs that were created, what we call tyrosine kinase, help turn that switch off and therefore stop CML. And so in terms of treatment, we also have to look at how to monitor the course. So once we treat, we want to make sure that we do cytogenetic testing, we do FISH testing, we do quantitative PCR. And then the final thing, which is not monitoring, is called ABL mutations. And that's going to get into where we look for resistance of CML. So when people are on a TKI for many, many years, and then somehow their CML is still progressing, we often look for mistakes or mutations in the gene that are making the CML resistant to that particular drug. All right. Now I've told you about cytogenetics, which is the chromosomes. And I also talked to you about molecular, which refers to the PCR or the DNA testing. And so when we talk about things like minor cytogenetic response or complete cytogenetic response, this is what we mean. So just as a baseline, when a person with CML starts out and you look under the microscope at their cytogenetics or their chromosomes, usually all of the metaphases, usually we say 20, so 20 out of 20 metaphases, 922, which is BCR-ABL. As we treat, you see the number of those chromosomes, the 922s, and when you get to 0 Philadelphia positive chromosomes, that's called a complete cytogenetic response, and that is what we try to achieve as one of the best early markers of an excellent response to therapy. With the new advent of newer techniques like PCR and quantitative PCR, we are now able to check even deeper. And then we go into molecular responses. And I'm going to let Dr. Pavlovsly cover that. But essentially, that starts at about 100% BCR-ABL transcript by an international scale. And it usually drops by log. You can drop from 100% to 10% to 1% to 0.1% to 0.01% and even lower. And as you can imagine, just logically, as you're coming down on that, your CML is getting deeper and deeper in remission. We ideally want to achieve what's on the bottom here is called complete molecular response, which is we cannot detect by the most sensitive method, the BCR-ABL in the patient. All right. What about treatment of CML? All right, so treatment I alluded to earlier is by drugs called tyrosine kinase inhibitors, which you may hear in the clinic abbreviated as TKI. So when someone says TKI, that's what that is. Essentially, that names a class of small molecule drugs that target that protein, the BCR-ABL translocation, that abnormality that happened when the 9 and 22 translocation happened. And what they do is they act to turn the switch off. So if the switch is left in the on position because of the chromosome and there's signals happening, this drug goes into that binding and turns it off, okay? And it leads to disease control, the cells stop growing, eventually they die, and people go into remission. But they don't completely get cured of the disease, and that's the important part, because continuous treatment and compliance with these oral medications is paramount to treating this. As an example, people who are on treatment for, let's say, 3-4 months, on great CML treatment, doing well, say, doc, I'm fine, I'm cured, I'm in complete cytogenetic response, you can't find any chromosomes, I'm gonna stop. Well, what generally happens is that we never, almost never kill all of the CML. And so then you took that, you took the drug away, the switch goes back in the on position and the CML goes back. And so it's important to have continuous long-term suppression of that BCR-ABL clone. And in the future, we're going to be talking about stopping. And I think we may cover that at the later point of the talk. But in the beginning of treatment, it's important to continue treatment continuously and maintain compliance. Poor compliance can lead to relapse of the disease, and it can lead to resistance. If you can imagine, the cells are growing, you put the TKI on, they stop growing, you take it off, they grow again, put them back on, they stop growing. You keep doing that, mutations can develop, and then the CML becomes resistant to the TKI that you were using. And so it's one of the things that can engender resistance. It's also important to remember, particularly if you're starting out in treatment of CML, is that all of these TKIs have some side effects. They all have a different set of toxicity profiles. Your doctor will know what they are, and they'll sort of try to match the toxicity profile with the patient. A person who has widespread lung disease or heart failure, they may use one medication. A person who has issues with strokes and things like that, they'll use a different medication. A person who has a very resistant mutation in their CML, they may use a third TKI. So these are all geared towards what can be used. The other challenge I think that I've heard, at least early on in our discussion, is that many of these are not available everywhere. And I think I'd really like to get perspective from around the world, where many of these drugs, although they're available routinely in the US, they may not be available in some of the countries outside the world. And so that's a big challenge that we need to help overcome. These are the available TKIs listed there. And I put just a few of the common sort of red flag side effects that we experience with these, imatinib or Gleevec, which leads to swelling, fluid retention, dasatinib, initially with low blood counts, but then fluid around the lungs, fluid around the heart. It can lead to pulmonary hypertension. Again, not very common, but can happen. Nilotinib or Tasigna can cause cardiovascular side effects like QT interval prolongation, can make your liver enzymes go up, can cause pancreatitis in some patients. It has an incidence of causing cardiovascular other effects such as heart attacks and strokes, but not as high as ponatinib, which is the last one. And bosutinib, we know, causes significant diarrhea, but among the others, it may be safer because it doesn't have as many of the cardiovascular side effects. And so that's often one that we use in patients who have risk factors. So that's sort of a summary, again, very high level. I'm not going to get into too much detail, but I wanted you to all understand the language that we talk when we talk about CML. All right, I'm going to hand it off to Dr. Pavlovsly, who's going to lead the discussion from here on out.
I'm going to talk about what do we have to know for success in CML in this area or in this year 2021. So from the practical point of view, I think it's very important to consider first what must we consider from the patient when a diagnosis and during the follow-up. So the risk diagnosis is very important because sometimes, and some doctors use it and it's recommended to use it to choose the TKI. I know that some institutions perhaps don't use more Gleevec or imatinib, but in some countries like Latin America or India, we are using imatinib as first line in low-risk Sokal score, for example. So the risk is very important at diagnosis. Comorbidities, it's very important because if the patient has different comorbidities and we don't ask them, we're going to give a TKI that perhaps then will make not better the quality of life of that patient, because for example, patients who are smokers or who have some lung problems or diseases, if we choose some TKIs, as you know, as dasatinib, for example, we are going to perhaps need to treat some important and some flashings or some liquid in the lung, edema, and pulmonary hypertension, and a lot of things that perhaps we can avoid if we ask the patient about the comorbidities. Another thing is the education, and this is important in some regions of the world because some drugs, as nilotinib, that we have to take it 2 times a day and with fasting, it's important that the patient is responsible and the patient knows that he must take into account the hours of fasting, so the patient must be very responsible. Another point is the treatment adherence, and this is a little bit responsible also of the doctors, because in every visit we must ask the patient if the patient, not only if the patient had received the drug, but if the patient has some problems or symptoms, for example, that take not to have an adherence of 100%. So if we don't ask, we will never know if the patient is for example, skipping some doses. And you know that skipping doses, what's the final result? The final result is a non-optimal response. And skipping 2 or 3 pills of imatinib, as some published data that you know that was published, concluded that if you skip 2 or 3 pills, you will never, along many months, you will never achieve a molecular deep response, and perhaps can never enter in a TFR program. So it's very important from the beginning of the treatment to consider the importance of the compliance of the TKI and to tell the doctor if you are having some problems with some adverse events of that drug. Another thing important, and that's very really very different, the access in different countries, is the monitoring, the access to the monitoring. And especially I am referring to the molecular monitoring, because perhaps to cytogenetic many countries have access to, but to molecular monitoring, and so standardized monitoring, that's perhaps a little bit more difficult in different countries. It's very important to have access to this monitoring, because also monitoring frequently a patient can also show us that the patient perhaps is not adhering to the treatment, because if we see fluctuations in the molecular BCR-ABL, we know that there are many causes, but one of them is the non-adherence to the treatment. About the toxicity management is what I was saying, that it's very important to have a good communication, and this is very, very important with between the patient and between the doctor. And this, the patient must have time from the doctor to have it. In the visit, we as doctors must not be in a rush, and we must ask what's happening, not only tell about the PCR or the white blood cells or the platelets, but also ask if the patient feels good. I always ask from 1 to 10, what's your scale of quality of life? So really, if the patient says, I am a 4 or a 5, something is happening there. So it's important to take into to ask if the patient has gastrointestinal events, for example, or the skin is having a problem because he's having rash all the time, or edema, or whatever it is about the adverse event. These are chronic adverse events that we're going to talk about it in a little in brief. So quality of life, as I have said, it's very important. And obviously the financial burden, that this is not a matter of the patient, but it's indirectly a very important thing, because the social security must give in different countries. This is very different, but in Argentina, where I am, we have patients who can afford the treatment, and patients who cannot afford the treatment and have really the treatment not given continuously. So this is a very important matter. What I was telling about drugs, that this is another point, is that nowadays we know that there are a lot of generics and copies. So it's important to know if we have an original drug, if we have a generic drug, or if we have a copy, and if that copy is a good quality copy. But because there are copies or generics of good quality, and some that they are not of good quality. So this is a very important to know, and to know what if you are receiving the same generic all the time. Because, as I have said, the chronic adverse events are the ones who perhaps cannot permit a good quality of life. And this is a chronic leukemia. This is a chronic disease. And we're going to talk about TFR, but we know that there's a little group of patients that can afford and can start TFR. So we must know that we must live the best as we can with this disease, and sharing what the symptoms that we are having to our physician, so we can resolve this going to a gastroenterologist, or to a pneumologist, or to a dermatologist to treat these slight or grade 1 adverse events, but that are they are not permitting us to live a normal life. And then we have the severe toxicities, as we know that when Dr. Tapan has mentioned, with ponatinib, the cardiologic events, or with nilotinib and dasatinib, pancreatitis, or pleural effusion. So that are the severe events that we must treat immediately. Are patients that will have a normal lifespan, and the optimal adherence will impact in the clinical results, and this is very important. Why we don't follow guidelines? Some doctors do not follow guidelines, so the patients, I think, that must know that these guidelines are very important, and perhaps they must know the guidelines of CML, because it's not the same to treat a patient in a clinical trial that a patient outside a clinical trial in real world. In clinical trials, it's very easy, everything, because it's written, and it's very different from real world. So if we know that we have guidelines, and the doctor is following that guidelines, you are going to be well treated. So it's very important to take into account the availability of an effective treatment, the treatment that is approved in your country, The adherence in the real world is different from clinical trials, and there were publications about more or less 50% of the CML patients that didn't have adherence to the first line. This was published, and most of them were young patients. So really, young patients are the most difficult patients. Also, the optimal monitoring response. Less than 50% of the patients outside clinical trials were monitoring according to published guidelines, and the patients with low frequency of monitoring have the worst evolution. That was, I said before, about the importance of the molecular monitoring. Monitoring every 3 months or every 6 months is a great opportunity to know if you are going well, if you are responding well, if you are an adherent patient, and if the disease is going down, and we have the expectation in the future to discontinue the drug. One of the most important things, and I've just put the importance of the guidelines about the ELN 2020 that has been published recently, the question about response monitoring. And this is very important because we are always talking about, I'm really fanatic about the molecular response because we have a lot, it's a very important tool, the response and the laboratory we use. The lab must be standardized so as to follow these points. So it's important to take into account, I'm not going to read all, but if you look at the failure column, you can see that one important question we are always asked by the patient, or we have many patients that come and ask the same question about the 3 months. If we have more than 10% at 3 months, must we change treatment? So these guidelines define that at 3 months, if you have more than 10%, this is a warning, but it's not a failure. It is a failure if you repeat it and it is confirmed. So the first molecular response, more than 10% of BCR-ABL, it's not a failure. And it's very important in this period of the first 3 months to consider if the patient has been adherent, but not adherent perhaps because forgot 1 or 2 pills. But this is a point that the doctors also have to be adherent, not to interrupt the drug because of slight events, because events of grade 1 or 2. I always say that the first 3 or 6 months or 9 are very, very important in the patient's life, because it's the moment where they are going to reach the first response. And perhaps in the first 3 months where really patients have a lot of toxicity, cytopenias, we must know how to manage this. And this is well managed in following guidelines. This is not perhaps the subject, because it's another subject, the management of toxicities. But if you, for example, have a slight neutropenia or platelets or a little bit lower than 100,000, for example, that's not a point to interrupt. And if you interrupt 1 week or 2, then the response is not going to be what you're seeing here in the table. You perhaps are going to see a patient that has more than 10% and has interrupted 2 or 3 times in these 3 months. So this is very important, just the first 3 months. In the 6 months, it's also important to obtain a good response between 1 and 10%, or less than 1%. Less than 1% is the optimal response. But if you have between 1 and 10%, you must also ask the patient if the patient is adherent, or if the patient is having also is being treated with another drugs, that perhaps those drugs, there are many drugs that can compete and can not let the TKI make its function, no? And for example, corticoids or antimycotics, or there are a lot of drugs that perhaps or chronic drugs are as in psychiatric treatments. So we can be we must ask the patients, what are they having apart from the TKI? Because perhaps there are patients that are having 5 or 6 drugs also, and this can be a problem at the moment of competing this with the TKI. So what is a failure at 6 months if the patient has more than 10% of BCR-ABL? This is a failure now at 6 months. At 12 months, we must have less than 0.1. That's the optimal point. But if we have more than 1%, we are having a failure. And every time we say that we are having a failure, we must think of changing the treatment, and we must make a mutational analysis, as it was mentioned before. And if at any time during the disease the patient has more than 1%, or a resistant mutation appears, or in the cytogenetic analysis abnormal clonal evolution appear, we must consider it a failure. So this table is really very important. The next. Well, and the contraposition of this is, I think, the opposite of the failure that I have talked a lot, is the great objective today of TFR, of the CML, that it's TFR. So I've just put only one model of the TFR studies. That is one of the biggest one, the EuroSky trial, that had included 758 patients. That one of the criteria, inclusion criteria, was that the patient must have more or equal than 10 years of TKI and a molecular response of 4.5 more than 1 year. And this, as you can see in the curve, what's interesting to know for those who perhaps are not familiar with this, no? And I want to perhaps to say something that is very important. The patients must have the pills every day, but there are a group of patients that are going to be very lucky that year by year will have a descending curve of BCR transcript levels, a descending transcript level, and the kinetic of that molecular response is going to go down. And if that patient included in wants to stop the TKI, that patient must share this with the doctor. Nobody must do it alone, because it's very, very it's dangerous. And why? Because you can have the disease again, and perhaps much more stronger. So this has to be talked with your patient, and you must have some criteria, inclusion criteria, and exclusion criteria to be defined by your doctor. Not every patient can be included in a TFR program or in TFR in the real world. So these are all clinical studies, and this is like the last part of a long journey of the CML patients. I think it's a very nice thing to talk with you this, and then I would like to know what do you think. But as you know, this curve is repeated in many clinical trials, and you can see, for example, in this curve, that at 36 months, half of the patients, 47% of the patients, had a molecular recurrence-free survival. The worst moment for relapse are the first 6 months, as you see. The curves goes down rapidly, but then the curves establish, and there are many, very, very few patients that perhaps have like late responses. So this is a very interesting point, but we have to be aware where to do it. If we have molecular labs, if we have molecular labs and results in 15 days, not in 2 months, if we have a lot of time in TKI, if we have a lot of time in molecular deep response, well, we must have all that into account. Just to share, what is the right dose? At the right part of the table, you can see the front line right dose, and you can see with imatinib, for example, we know that 400 once a day is the front line dose. With dasatinib, 100 milligrams one day, once a day. With nilotinib, the front line is 300, or well, in some this has been presented by Hockhouse in the EHA 2 days ago, and this is what he said. But the approved dose of nilotinib is 600 BID, 3 BID, bosutinib 500 once a day, and ponatinib 45 milligrams, and then lower the dose. For salvage therapy in the other side of the curve, it's mostly the same, but for nilotinib, yes, we have 400 BID, and for the rest, as you see, it's the same. And the difference is that for ponatinib, it's 45 milligrams the start, and when the patient obtains less than 1%, we can lower the dose and obviously monitor the patients and see if the patient still responds to that lower dose.
All right, thank you. That was amazing. Really nice review of monitoring and patient experience throughout, including PCR and also stopping therapy, what we call treatment-free remission, or TFR. So on this page, there are a bunch of questions. These are questions that come up when Dr. Pavlovsly or myself are in the clinic, when the patients ask us these questions. These are questions which may be in the minds of the patients and patient advocates who are on the seminar with us. And the last are just a few of the many questions we may think of that we want to ask our patients. And so I'll leave these on the screen. Let me just go ahead. And I think the next part of the discussion is going to be sort of the patient experience. And we really want to hear from our patient advocates on the line to kind of go over what we said, if there were any clarifications you needed, and give us an idea of the journey and what questions are important, and what would you tell fellow patients about what to ask and things like that. And I'll go back to that slide. It's just so we have this in the background to help frame some of our discussion. So I'll open up to you. Thank you.
Thank you. That was wonderful. First of all, amazing presentation from both of you. And I think this is so important, not just for patients, but patients, caregivers, as well as treating physicians to really understand. Now, CML and, thanks to TKIs, a potentially fatal condition like chronic myeloid leukemia being converted into a chronic manageable condition, and having patients live, receive not only an extension of life, but with the quality of life. At the Max Foundation, we have seen over these years, almost 2 decades now, thanks to the patients and our being part of the patient assistance program that we call Max Access Solutions. I think what has been at the foremost of our interventions has been the fact that we have involved the patients in understanding the disease, understanding the management of the disease, the importance of compliance, of good adherence behavior, and putting the patients in touch with each other. We have support groups for CML patients in all the countries that we work with, and that provides a very safe platform for patients to share and learn from each other, This is a very unique situation. Here we are having leukemia patients live long and live well, but at the same time, they have what is called the Damocles sword hanging always above their head, because they don't know when the current situation is going to change and how they have to equip themselves in order to deal with that change, like when the disease progresses or when they stop responding to treatment or when there's a mutation. And then compliance, drug fatigue. This is something very real, having to live with cancer. Your role at home changes, your role at your workplace, there is discrimination, there is still stigma. So using the patients, the patient groups, and the patient support meetings that we organize, we try to bring the treating oncologist and the patient together. We bring caregivers together. We bring various stakeholders in the program together. And it is a continuous exercise. It's just not a one-time intervention. I would like to definitely now, ask the patients to take over our, we should call them patient advocates, because each one of them is truly an inspiration and stands as an example of perseverance, discipline. Andrian, maybe you would like to say something first.
Okay, I try. I'll try. Easy. Thank you. As we all know that since the development of Martini or TKI or other TKI, CML patient prognosis has markedly improved. Most patients diagnosed with CML can now expect to live with the disease rather than die from it, right? However, as Dr. Tapan and Dr. Carolina said, that current CML treatment guidelines recommend most patients who achieve remission treatment guidelines recommend most patients who achieve remission with TKI therapy continue taking the treatment indefinitely or long-term treatment, which has a deleterious effect on health-related quality of life. Anyway, even in current treatment guideline, there are criteria for some patients can stop therapy, or as we know that from the screen is we talk about do you consider TFR as an objective in CML? For me in Indonesia, in my humble opinion, a patient who wants to stop the therapy need extra financial support because TFR is done outside a clinical trial. The patient must pay for the molecular test at his own expense, and as we know, the budget for this molecular test is very expensive. I think TFR, we are considered about TFR, but for me, or I think from the perspective of the patient nowadays in Indonesia, it's not realistic for us today because there are consequences for when we stop the therapy, right? And I think about the KOL. I think it's normal for patients to experience ongoing side effect of treatment. For example, we know that fatigue, bone marrow, cramps, etc. But we have to. I think it's not only that, but also it is common. It is common for CML patients to experience also emotional problem such as anxiety, depression, and social isolation. That I didn't find these things in the presentation. But for me, it is important also. In this case, besides adding to requirement the involvement of doctors, or perhaps psychologists, I think it may also require patient assistance. For example, we in Max Family initiate a peer-to-peer sharing and discussion around the world. And I think this session is not only for the patient only. I think it is also important for caregiver, especially about the hot topic is pregnancy topics for patient who for women who still unproductive. I think it is important also.
You know, the emotional issues that happen with patients, the anxiety involved, the multiple bone marrows, the multiple visits. These are things that we didn't cover, but I think that you bring up a very good point. In terms of TFR, you know, what you mentioned about having TFR actually causing more bills and more cost to the patient. I didn't think of that initially because in the US, many of this stuff is covered by insurance, but I think around the world, patients have to take the cost of getting the frequent monitoring that they're getting once they are in TFR, the monthly PCRs and things like that. And then in my practice, and I think maybe others can speak to it, but you know, when I offer TFR to many of my patients, particularly the older patients, they actually don't want to do it. They'd rather stay on the TKI, maintain their PCR, feel good, and not worry about anything else. Because once you take them off, then there's more doctor's visits. They said, look, just leave everything as is. I'm living a great life. I don't want to touch anything. I think the few patients that do actually ask me are the younger patients who want to start a family and have pregnancy. Dr. Pavlovsly, is that your experience or?
Not so much, because I have two things, and what Andrea said is really very important. So I answer both of you. First, Tapan, in Argentina, as we have a lot of difficulties in sharing TFR with our patients, because I have participated in a lot of clinical trials of TFR, but that's not the reality. So what I have done is to write the project, and I have organized a TFR project in Argentina. So 50 patients were included. But unfortunately, we could not enter that 100 patients. We have the support for 50 patients. So that was complicated also, because the patients were under a similar protocol, but it was not an industry protocol, but that was also what it wasn't the real world. I have done the real world in TFR with some patients alone that didn't enter that protocol, and really it's risky, because the patient thinks that, and I understand what you say, perhaps the patient are very anxious, and perhaps this happened to you as patients, that you are very anxious to interrupt the drug, and then you feel happy, but you are more anxious for that result. That result it has to make you happy. So I always one of the important things that we took into account in the recommendations of Latin America that they are going to be published now for TFR is the psychological point of view. Because if a patient previously, you know, your patient is a patient that is anxious, or that it's a little bit problematic because doesn't understand very well, it's better not to stop, because that patient perhaps is going to get a depression, or is going to be more anxious, because that patient must have the stability to know that fluctuations are normal, and that perhaps that patient must have the pill, and that's not a catastrophe. So the psychological point of view is not only important at diagnosis, as you have mentioned, but in TFR. And another point of view to make it in the clinical reality, in the real world, is the frequency of the TFR and the rapid results. That's not common in the real world. So I think if you want as patients to make TFR, just make it with experts. Go to see an expert in TFR, a CML expert, and just share with him your opinion about this. Well, and I have, in Argentina, there are a lot of patients that want to interrupt, perhaps as different as in MD Anderson, but well, we are another part of the world.
I find it very interesting, Doctor, that you use the word interrupt the treatment, you know, looking at TFR as interrupting the treatment. Dr. Jude, you've been under treatment for 17 years. You are a physician yourself. Would you like to say something, you know, about your quality of life under TKI treatment vis-a-vis the talk about stopping treatment?
I'd like to tell you my views on TFR because basically I've been so long on Glivec, 17 years, and it has been since I was started in 2004. The entire experience with Glivec has been so smooth, and so it has not ruffled my whole you know, experience of having CML to such an extent that I wouldn't think of discontinuing the drug. I agree with what Dr. Tapan said a little while ago, that I'm especially and I'm one of the elderly patients. So I don't think, I would look at it as everything's going so well, why upset the apple cart, and why should I get off the drug when I don't know what that could entail for me, whether it would suddenly make life, what was smooth sailing a very rough and stormy thing. So as a patient, I don't welcome the idea of a TFR if everything is going well. Even if I have, because of being very compliant all these years, I've not really encountered a reason for having it. So that would be my view with regard to TFR as an objective in CML.
It's a very good point of view. It's important to know that. For us, it's very important to hear your thoughts, no? And the other ones, what do you think about TFR, Najha or Kel?
Okay. Just to share my my experience, I'm currently taking nilotinib 600 and 300 BID. So since November as a first line. So I'm happy with the. I mean, I don't have any very major side effect, but it's just like when I do some reading, I'm very concerned on toxicities. You know, the side effect, especially on the cardio, everything. But the rest, for me, I'm very grateful that Malaysia have a MyPET program that I getting the treatment, the medications. It's just like for me, for 6 years, I'm taking nilotinib. I'm afraid of the side effect, more on the side effect side lah. And then I'm considering to have the TFR because I've already asking for my hemato to get the, I mean, whether can I go into, you know, this program, because Malaysian government, hospital government is already started the program, but they already, you know, identify those who are eligible. So the doctor said I have to, you know, still taking the medication. So for me, I think that some patient, as someone said that just now, when you offer your patient the TFR, but sometimes they don't want to take it because they are very comfortable with the medication right now. But some of the younger patients, they are eager to have that TFR. That's why that's one of my you know opinion lah for me. Thank you.
That's really interesting, Najha, when you see, because these are definitely two different viewpoints. And we do have patients from all age groups. I have seen, I have actually done interventions with patients who were 3 years old, 4 years old, 10 years old when they were diagnosed, and they have now grown up into 15, 20, 28-year-olds. They've want to live their lives as normally as possible. And yes, I think it's a very valid point that the younger the patient is, and if it is a female patient wanting to start a family, then TFR does look like a very good option. And that's a very, very important point, actually. The two ends of the spectrum, where Dr. Jude and Andrian also said that, why upset the apple cart when everything is going smooth? And then the perspective of someone who's young and who's looking at living, on lifelong treatment, and then how TFR might appeal to that segment of the patients. Definitely a very important point to consider. I do think it's also very important, therefore, to talk about quality of life and how comfortable a patient is on TKIs, and then the challenge of dealing with side effects and how that impacts quality of life. Maybe one of our patient advocates would like to speak about that, Ed.
Good morning. As far as quality of life, let me speak about it from a personal perspective, and as far as what I've seen amongst my fellow Filipinos. Personally, I was able to pretty much resume all of my normal activities within 6 months of starting treatment. When I first diagnosed, ironically speaking, I was part of I was doing fundraising for leukemia, and I didn't even know I had CML. So during the training, I had the routine checkup, and turns out I had CML. So the big question for me was I supposed to continue my fundraising via half marathon, right? So against all advices, I continued it. So I guess I was able to, so my quality of life, I guess because I was an athlete before, so I was pretty strong, even though I've lost a lot of weight. My fish test was off the charts, and but I was able to do these things. I would say that I was able to do this through the encouragement of my support group. I'm not sure if I'm supposed to mention the group that I was with, but I was Los Angeles based before. So basically, it's a big leukemia fundraising organization that runs. So because of the emotional support that I got, it encouraged me to continue working out, obviously guarded. And I was even able to set a personal record on my half marathon. I think I was able to complete it in 2 hours and 20 minutes. Not bad for a newly diagnosed person. Sad to say that was my last run, but I was able to meet.
There'll be more.
Well, I don't compete anymore, so I still walk. I don't run anymore, so. So as far as quality of life, I was able to pretty much resume my career. Currently, I'm an entrepreneur, and I'm still as active. I just need to be watchful of not overcommitting to commitments, obviously. Otherwise, I run the risk of exhausting myself. As far as the patient advocacy work, it has exposed me to various folks that are CML survivors. What I've noticed is that people are going through life with CML. Some are not very adherent to treatment protocols or drinking their medicine, so to speak, and some are very fanatical. What I've noticed is people get used to the side effects or the lack of quality of life and think that's not even a side effect. In fact, I had a conversation yesterday. This friend of mine from 9.5% jumped up to 3.35%. And she says, no, I'm just tired during the afternoons. I'm saying, are you serious? BCR-ABL of that spike is worrisome because you're 3 years in. So I'm telling her, you better get tested for mutation testing. But the problem is, I don't think it's available here in the Philippines, and it's very expensive. So TFR is like so far away from my personal experience because I'm not even PCRU at this point. I'm at MMR 4.5 after over a decade. So for me and for my compatriots, my fellow Filipinos, they can't even maintain the medicine because it's really inaccessible. You have to go through government to receive subsidies, and you have to fall in line with COVID raging on, especially in the capital. It's really hard to access, and the folks that are from far-flung islands, they just die, literally die. I've seen people that are advanced in their CML, whether it's accelerated or blast, or they don't even know, but all they know is they had the initial diagnosis of having CML, Philadelphia chromosome, and medicine is just hard to access, especially from the far-flung region. Although there are programs now. The Philippines just passed universal healthcare. So they're now, it's almost free now, especially for imatinib. But still, people are uninformed, although we try to tell people, yeah, it's available, this is the process. And I've heard someone say before, there's fatigue of just drinking your medicine and keeping healthy. I just hear people just getting used to being sick. So they think they're normal, even though they have a very low quality of life. Like my friend, she's at 35% BCR-ABL. But she thinks she's normal. It just so happens that she's tired every afternoon and sleeps it off and unable to work. So I guess the mind plays tricks on you when you're in a situation where you get tired queuing in lines to get government subsidies. I'll tell you how unaffordable monitoring is in the Philippines. It's basically 1 month's wages. And it's very difficult to get subsidies for it. It's like a full-time job. So for me, I'm a little bit well off. I can afford it, and even I don't think TFR is achievable because I've been bouncing around between MMR 4.5 and MMR 4. I've never achieved PCRU. So although I would say that when I was younger, when I was still a hunk, that I thought it was achievable, but things turned, it didn't go as planned because I averaged 3% BCR-ABL for first 3 years of treatment, even though I was taking the dasatinib. So I guess, by the 5th or 6th year, I just got used to it.
That is the harsh reality.
Yeah.
That is the harsh reality.
Yes, yes.
Thank you.
And
Thank you for,
yeah. So you just accept things like that. So.
But then, there is definitely acceptance, and it is a harsh reality. And I would really like to, say here that all of us in this part of the world, in South Asia, in the Asia Pacific, I think the patient support groups play a very, very important role in creating awareness, in encouraging patients their co-patients to find ways and means of managing, raising resources for doing the tests. Yes, it is the bulk of the patients, it is unimaginable. And through the access programs, though patients do receive the medication at no cost, they don't have resources to avail of that facility itself, let alone monitoring tests. Dr. Vaz, just to kind of, round it off, would you like to, I know that, Najha is there with Max family, and then of course there is Touched by Max in the Philippines, and there's Friends of Max in India. Jude, you are a pretty strong patient advocate on the patient group. Would you like to just say a few words on that?
Yes, I'd like to say this, that besides the doctor and the drug, which is very paramount in the treatment and management of CML, and I was lucky to have Dr. Tapan Kadia, who is an excellent doctor, and this wonderful drug, Glivec, imatinib mesylate. But very, very important in the scheme of things is to have a good support group. And with regard to that, I must say that Friends of Max, which is the largest CML patient support group in the world, which deals with roughly more than 14,000 patients across India, is a very phenomenally wonderful group to be a part of. We have, as you know, Viji Venkatesh is the dynamic head in the country who manages this. And we also have very nice, tight chapter groups across India. As you know, India is a very big subcontinent and things differ widely from part to part. So we have, for instance, in Bombay, where I am, we have a group which has regular meetings, and we have so many different programs. We have literature and booklets that are printed, and they have to be printed in diverse languages because there are different people speaking different languages across India, and that is catered to. Then we have a large number of activities for our groups. And once every other year, we used to have what we called a leadership summit, where in the metropolitan cities like Bombay, Calcutta, Delhi, Chennai, and meet with a wide spectrum of people from across India who would then share and learn from one another. It was a very wonderful thing to be part of, and it allowed us to, amongst ourselves, make deep friendships with people who had similar experiences with regard to CML. Yes, it's a very big, massive support group, the Friends of Max. It involves at least, Viji can correct me, but I think it's around 292 doctors involved in the group. So I'd like to say how important that is with regard to compliance, with regard to testing, and being able to share these various things and how they impact on our disease.
All right, thank you. I think that's some really great perspectives. And I think we covered a lot, and I actually learned a lot from the patient perspectives, in addition to from Dr. Pavlovsly and the rest of the group. Any last thoughts as we sort of wrap up our patient-focused, patient perspective seminar on CML? Any last thoughts from anyone? I think, like I said, I think we've covered a lot.
I just want to thank also and say that what we have talked as doctors, it's important, but much more important for me is having heard what your thoughts. I like, and I think it's very important sharing this head to head. What do you think? What can we give you? And in Argentina, we also have a patient group named ALMA, and it's very important in every country because you can share with other patients. But if you need anything of your doctor, we will always be there for you. In my case, anything you need, I can be there to answer anything.
I would also like to say here at this point that it's wonderful to see patients access or rather make use of technology. And there is an amazing presence of patient groups on social media, and a lot of information is shared through their presence on social media. I know, Andrian, I see you share so much on your Instagram page, and you're really an inspiration. And of course, Najha, with Max Family, And I think it's very important that we harness the power that technology gives us. We have WhatsApp groups through which we share, instantly we can share messages, and we use that for promoting messages on compliance, reminders, and now with the pandemic, like our friend said, it's put a full stop to a lot of face-to-face and physical meetings. But what we've done is, yes, everybody's discovered Zoom, and we have virtual patient meetings now, patients from Bangladesh, patients from Sri Lanka, we're talking to each other, support virtual meetings every month. And it is so encouraging, it is so rewarding to see patients from the interiors whom one would never have expected. They come and sit at the meeting with their smartphone, and they like to be seen. So their video is on, their audio is on. They bring their family members, say, this is my wife, this is my little child. And every meeting is actually a celebration of life. And I think that is what it has been given to CML patients through TKIs, through the wonderful management by their treating physicians. I'm sure both the physicians on our panel today, will agree how wonderful it is for you to see your patients do so well and to become part of your patients' new normal. I think that's something that is really wonderful. So I have never ever seen despondency, or I have never seen defeat. I have never seen sorrow. I have never seen disappointment in any of our CML patient group meetings. There's only courage, there's only strength, there is only this desire to live well, to continue to live well with everybody and take everybody along with. And I think we owe a lot to our treating physicians to be such an important part of this journey.
Thanks so much. I think that was a great summary of our talk today, and thanks everyone for participating. So, bye-bye.
Thank you very much.
Thank you.
Thank you very much.